of papers that are coming out. I think it's nice to get a regular journal club just to get all of us tuned to the field, learn the concepts, and get a lot more of us kind of doing research in this field. It's really exciting. So the first talk is going to be by Dr. Vessel, Mina Vessel, who is our incoming chief resident.
All right, thanks for handing it over, Dr. Boyake. And just wanted to say thank you to the Seattle Science Foundation for the opportunity for our residents to present today. We're very excited to be here. So as Dr. Boyake mentioned, we'll be discussing artificial intelligence in spine surgery, which is definitely a hot topic these days. My slide is a little sticky here. I wanted to just introduce our residents, as Dr. Boyake had said. We have 3 residents, including myself. I'm a PGY6. My co-resident, Sean Adams, will also be presenting. We have Dr. Sharma, who is a co-PGY6 here, a previous Spine Fellow alum, and Dr. Jane, who is a current Spine Fellow. So I'll be doing a brief overview of terms in relation to artificial intelligence, machine learning, and deep learning, just as a brief primer before we discuss my article in depth. So artificial intelligence is a large umbrella term that was invented sort of in the 1950s sort of era. So it preceded the development of computers, big data, and large computing processing. But it was a philosophical idea that we can take data and turn that into advanced algorithms in order to accomplish a task or mimic human behavior. And since then, we have improved our technological speed and capacity and also acquired a lot of data. And so now we've moved into the era more of machine learning and deep learning, which are both subsets of artificial intelligence, which is an umbrella term. So next we'll talk about machine learning. So machine learning utilizes statistical methods to allow a machine to make data-driven decisions. And so when we discuss machine learning, we are talking about answering specific questions utilizing data. So the example that I've used in the past is if a computer is to decide between whether a picture is of a caterpillar or a butterfly, it may ask a lot of yes/no questions to arrive at that answer. Does it have wings? Does it fly? Does it have legs? Is it on the ground? And by answering all of those yes/no questions, it will arrive at the answer. And so that in very basic form is what machine learning is doing in order to arrive at the answer. Of course, machine learning is very dependent on having good data and a large data set, as well as the efficacy of the training that it undergoes in order to perform well under simulation circumstances. Next, we'll discuss deep learning or neural networks. So this is the next iteration of machine learning and is a little bit more advanced. Much like the neural networks of the brain, that is what deep learning is based off of. And so instead of more of a binary form, as we had discussed previously, it's a little bit more multi-layered. We're thinking of things like neural networks where some are activated, some are not, some are more activated than others, and the activations differentially occurs and allows the computer or the machine to arrive at the final answer. And so we have some control over which layers are and are not activated and how those layers are designed. But in general, we still think of neural networks as a black box, much like we think about the brain, in that we don't quite understand all of the layers that are occurring, how they're designed, and why certain layers are activated and some are not. But we do know that neural networks can be effective if applied appropriately. So deep learning and neural networks do require a lot of training time, but they have reduced test time as compared to machine learning. So that is our brief primer on artificial intelligence. The article that I'll be discussing was an article that was published in JNS Spine entitled, "Can Machine Learning Algorithms Accurately Predict Discharge to Non-Home Facilities and Early Unplanned Readmissions Following Spinal Fusion? Analysis of a National Surgical Registry." So this is a paper put out by a group at Mayo. The background on this article centers around spinal fusion and it being a very common procedure that's performed in the United States, approximately 450,000 cases annually. We also know that the outcomes related to spinal fusion are of great interest to practitioners, health systems, and our patients. So in particular, this group focused on the outcomes of non-home discharge and unplanned readmissions. And particularly, they're focusing on these two as their key cost drivers for overall hospital care. And so in this paper, they look at these outcomes and they try to come up with prediction models that can attempt to understand the factors behind ending up at a non-home discharge or an unplanned readmission. And so their hope is that if we're able to delineate the factors that lead to those undesirable outcomes, then maybe we can change our practice and impact the cost of care. So this is an attempt to utilize big data to answer a complex question. So the study design is a retrospective cohort analysis of spinal fusion, specifically cervical and lumbar, which were performed between 2012 and 2013 within the American College of Surgeons NSQIP database. And they actually had almost 60,000 patients in this study, which is a huge N. As I had said before, the primary outcomes of the study are one, discharge to a non-home facility, and then unplanned readmissions within 30 days. The covariates are listed here. I won't read through those just for sake of time. But the nice thing about machine learning is that you can utilize a lot of variables in order to end up at your final decision. And so the basic premise of this study is how can we intelligently predict these two undesirable outcomes with using machine learning, and which model within machine learning is really the best or the most accurate at predicting those outcomes. In terms of statistical analyses, so there were a large amount of missing data within the study. So about 0 to 60% missing data. That was not expounded upon greatly within the study itself, but we do know that they had to employ some data imputation in order to fill some of the gaps that were present in the study. The machine learning models which were employed are all listed here. So these are all of the ones that they tested and then cross-compared against each other. The GLM is similar to a linear regression model, which I think we're all familiar with. A GLM net is similar to that, but sort of a derivation. LDA is a linear discriminant analysis. They also used a naive Bayes. ANN is advanced neural network. RF is random forest, and then GBM is a gradient boosting machine. And then the RF and the GBM give us a closer look into which variables are most important in determining the outcome that we're looking for. In terms of analyzing each of the models, there were multiple characteristics that they looked at in order to compare which model was best. And I've listed all of those here. You may recognize some of these terms from basic statistical analyses. Some of the newer ones that were new to me in learning about machine learning were ACC and AUC. So these are two different ways to look at the accuracy of a model. So the closer each of these values are to 1, the more accurate a model will be at predicting the outcome that you're looking at. Demographics are listed here, nothing terribly surprising. Median age was 57, 51.5% male, 82.6% Caucasian. The overwhelming majority of these patients were from home at 98%. 97% were independent before surgery, and generally these patients were in ASA2, so that was 51.2% were in ASA2. This is a little bit of a busy table, but it does allow us to understand some of the behind the scenes of the data. So of the cohort that did end up going home, the overwhelming majority of these patients were coming from home to begin with, so about 99% of them. The patients that ended up at a non-home facility, there was greater variability here. So some were coming from an inpatient facility, Some were coming from a nursing home, outside ER, and then a transfer from another source. So I think these data are unsurprising. In terms of functional status, the patients that went home, the majority of those were also independent at baseline, so 98%. And then again, with non-home, there's a little bit more variability in that population. So 89% were independent at baseline, but then 10% were partially dependent, and then a couple other percentages were totally dependent or unknown. In terms of model efficacy, so again, a little bit of a busy table, but the overwhelming pattern here is that all of the different models which were tested were actually quite accurate in predicting a non-home discharge. So you can see that reflected in the high AUC and the high ACC values. It is also helpful to see that there was a high negative predicted value associated with each of these models. None of them in particular really stand out as the best model, but it was nice to see that they all somewhat accurately predicted a non-home discharge. The variables of importance that seem to be a strong theme between each of the models are listed here. So those include advanced age, inpatient surgery, days from admission to surgery, higher ASA class 3 or greater, and then some of the pre-op labs, including the albumin, ALP, hematocrit, and INR. So I think, these variables overall are unsurprising, but do help us sort of underscore which variables are most important. So looking at the other primary outcome, unplanned readmission, so there was a 4.5% rate of readmission within the cohort. And you have to remember that this is a cohort of about 60,000 patients. So not too many patients were in the situation where they were getting readmitted. Because it was such a low frequency outcome to begin with, that's what made it more difficult to create a good prediction model. And so you can see that amongst all of the models, none in particular really stands out as the best, and they all have somewhat similar levels of accuracy in predicting this outcome. And so it was a little bit less efficacious than the non-home discharges models. They also ran analyses with the unimputed data, and unsurprisingly, the model accuracy didn't decline for both outcomes with the unimputed data. In conclusion, these models accurately predict non-home discharge and improved with imputed data sets. The models less accurately predict unplanned readmission, and the advanced neural network carried the highest AUC. The strengths of this study was an attempt to convene big data into an accurate prediction model, which, as Dr. Boyake had mentioned, is really an emerging area of interest within spine. So we have to commend this effort for trying to spearhead that initiative. The limitations of this study include the degree of imputation and missing data. So a good model is really dependent on having good data to begin with and very good training for the model so that it can accurately predict things in the future. The NISQIP database is an excellent effort, really a Herculean effort to sort of improve quality within the surgical arena. But we do have to remember that it was not originally designed as a spine database. And so some of the variables that we care about as surgeons are not necessarily included in there. So things referring to preoperative myelopathy or status of incontinence pre and post surgery are important to us and may influence a discharge to a non-home facility or functional independence. And so those are things that were not included, but may actually be more influential than some of the other covariates which are analyzed in this study. The study does require validation outside this cohort. It is nice that they had a large N, but we have to remember that there was a lot of missing data. And so we don't know to what degree imputation has affected the outcomes and whether this population is representative of each of our own individual populations at our own institutions. So the take-home message of my article was machine learning can accurately predict outcomes in spine surgery and underscore key variables of importance. And we have to remember that these variables are drivers of cost and outcome. And so machine learning can really do more than what we can do as humans, because it's taking all of this big data and hopefully helping us understand some of the mystery behind our outcomes to allow us to make data-driven decisions and also change the practice of medicine. So, thank you very much. And I believe we'll be taking questions either now or at the end, but I'll hand it over to the next speaker.
I've got a quick question, if I may. That was a great review of the paper. You put up the numbers with the AAC and the AUC, as well as the negative and positive predictive value. Is there a standard threshold that says the AAC or AUC has to be above to be meaningful? Like, is it 50, 60, 70, 90? I'd sort of intuitively think that if you want something to be very predictive, you're going to need an AUC above 90. Is that a common thing? And then the second question was, you said that the negative predictive value was 9.97, I think it was, which was good. But isn't the positive predictive value important in this as well? And the positive predictive value was exceptionally low, I think, in this one.
Mm-hmm. Yeah, so two different questions there. I appreciate both of the questions, Dr. Lieberman. So the first one refers to the accuracy and how to interpret those numbers. So I look mostly at the AUC and looking at these models and determining their efficacy. So in very simplistic terms, AUC of 0.5 is basically saying that your model is a coin toss. So regardless of the data that you put in there, you're flipping a coin and you may end up with one outcome or you may end up with the other. The closer we get to one, obviously, the more accurate the model is. In actuality, getting a model that has an AUC of 1 is exceptionally difficult. So for me personally, I think something that is predicting above like 0.7 or 0.8 in terms of medical outcomes is pretty good. I'm not aware of a standardized threshold, like a p-value or something like that is maybe something that you're looking for or referring to as a hard cutoff. But I think something that is able to sort of more accurately predict than 0.5 is encouraging. And then I think that the AUC values that they obtain for the non-home discharge are also encouraging, at least more so than the unplanned readmissions. Your question in reference to the positive predictive value and the negative predictive value. So the positive predictive value, as you all know, is referring to the cases of true positives over the number of positives. So we have to remember the way that the variables outcomes were defined in this study. So we're sort of identifying a double negative in the negative predictive value, and then the null hypothesis in the positive predictive value. So you are correct in saying that the positive predictive value is probably of greater interest, in that it's actually looking at what the model is predicting. But I think you have to look at both at the same time, because it is two heads of the same coin. If you have a high positive predictive value, but not a great negative predictive value, that model is not necessarily interpretable the same way. So I certainly understand that in our eyes, we want to look at the positive predictive value and maybe have more clinical interest in that. But for me, knowing that a model can also negatively predict is also helpful for knowing how to apply the model appropriately. So in this one, since the negative predictive values were so high, the way that this model can be more appropriately applied is to the opposite of the null hypothesis. That being said, in machine learning, the larger problem with machine learning is trying to predict an infrequent outcome. So most of these patients were discharged to home. And so we're trying to predict an infrequent outcome. And that's what sort of makes these algorithms difficult, is that we're trying to predict something which doesn't occur very often.
Thank
Yeah,
you.
let me
Now
just
I'm even
add.
more confused.
Let me just add. Let me just add to that. Dr. Lieberman, yeah, you're absolutely right. I think the negative predictive value is good, but the positive is really not good. So these models are not ready for prime time. Is the bottom line. You need to have good positive predictive value in addition to a good negative. And the negative is in the 90s. Positive is not acceptable. So they're not ready for prime time yet.
Fair enough.
Next presentation.
All right. Good morning, everyone. My name is Nikhil Jain. I'm the fellow here at University of Louisville, and I'm going to be talking about artificial intelligence-based hierarchical clustering of patient types and intervention in adult spinal deformity surgery. And this is a move towards developing a classification. This was done by the group led by Dr. Ames and the ISSG and the European Spine Study Group. A little bit of the background, all the current classification systems in adult spinal deformity are based on radiological parameters. We know the widely used SRS-Schwab classification has all the important sagittal and coronal radiographic parameters, and multiple authors have correlated with them with patient-reported outcomes in numerous publications. But what is lacking is essentially a comprehensive classification that also incorporates, in addition to radiographic parameters, clinical, demographic, frailty, and different various parameters to study the complex interaction between them. And that's one of the limitations of the current classical statistical models, is they cannot do. Here's where AI and machine learning steps in, is that it can handle massive amounts of data. It can look at complex nonlinear associations, correlations, classifications, which is beyond some of the classical mathematical models and also some of the natural intelligence of human capabilities. So the objective of this study was to use such AI-based clustering analysis and apply it to patient types and surgical intervention categories and apply them in surgically treated deformity patients, to move towards defining a classification that kind of incorporates all these parameters and also gives a meaningful outcome in terms of value, quality, and safety of the surgery that we do. The data was collected from, the patients were collected from a prospective multi-center adult spinal deformity database, one from the US and one from Europe. And they included patients, adult patients with radiographically confirmed ASD criteria, which is standard for the SVA, pelvic tilt, and all the radiographic parameters. And they'd already been planned for surgery and had minimal, and after surgery had a minimum 2 years of follow-up. The data was studied in two different categories. First is the patient parameters, which is the objective demographics and radiographic variables, and the subjective patient-reported outcomes. The second category was surgical parameters, which includes all the surgically relevant variables such as number of levels, fixation, blood loss, EBA, length of stay, and etc. The analysis itself they did a hierarchical clustering. It is an unsupervised machine learning technique, in that unsupervised is that the data itself, the computer is fed data, which is not structured. It's not labeled as dependent or independent variables. It's more of the machine or the algorithm to figure out or make sense of all the data that is fed to it. And the endpoint is to come up with clusters which have a similarity, high intergroup similarity and a high intergroup dissimilarity, so that in the end you have manageable discrete subgroups which you can then study. The animation below is kind of just a representation of how the clustering occurs. It's stepwise hierarchical, so it starts with the closest 2 points, makes them into one cluster, then moves on to the next, and so forth, till the optimal number of clusters are developed. And the figure on the right bottom is the dendrogram, which is formed, just showing the lineage of how the clustering was done. So for this, as we said, they studied the patients in two different, or the data in two different parameters. One is the patient and the surgical parameters. Some specifics, there are many ways to do hierarchical clustering. They used what is something which is called the clustering was built on ward distances and optimized with the gap method. In a very simple terms, when you combine two data points, there's a cost to it, and the cost function here is the sum of squares. So you want to minimize the sum of squares and collapse data into discrete groups. And the gap method, which we'll see later, is basically to come to a conclusion of how many clusters are optimal for this data. Once they had the surgical and the patient clusters, they created something which is called a surgical efficiency grid, which is basically in these clusters, they looked at 2-year patient-reported outcomes and the incidence of complications. Overall, they included 570 patients with a mean age of 56 years, and 78.8% were females. Well, the table is gives all the variables and the data, which we don't need to go into here. These are the surgical parameters for the entire cohort, incidence, the mean, standard deviation, and the values are given here. So for the patient parameters, this is cluster number 1. The graph on the left is the K method, or the gap statistic, which basically shows or gives an indication of how many clusters for this given data is optimal. And in this case, it was 3. So they formed 3 clusters based on similarity metrics for the patient variables. So the table on the right, which we'll go into detail in the next slide, is basically, it summarizes all the variables in the 3 clusters that they found, and which was, all these 3 clusters were statistically significantly different, but had in themselves have similarity, which we will see here. So this is kind of what the outcome is. The dots are the patients and the colors are basically the different clusters. They form 3, and we'll start on the right first. The top one is the young coronal group, is cluster 1, with the youngest patients relatively normal alignment, but have a high coronal deformity in terms of cob angles and a low incidence of previous surgery, and had the best baseline patient-reported outcomes. The second one is the old revision category, so older patients, high sagittal malalignment deformity, high incidence of previous surgery, and the poorest baseline patient-reported outcomes. And then the third cluster was the old primary ones, which were kind of fell in between, slightly older, but intermediate values for the COB and SVA, and a low incidence of previous spine surgery. This is for the second group, the surgical parameters. Based on that, the optimal number of clusters was found to be 4, and the table again summarizes these values, which we'll look at in 4 different clusters in the next slide. So starting on the bottom right was the 3-column osteotomy group, which they found had predominantly 3-column osteotomies and the highest number of levels fused. The second in the top left is the no osteotomy, no interbody fusion group, which they found average of 10 levels to be fused, but did not have any osteotomies, interbody, or pelvic fixation to them. The third in the top right is the interbody fusion group, lowest number of levels fused, but the highest use of interbody cages. And then the fourth is the SPO group, again, high number of levels fused and predominantly SPOs as the method of correction for these patients, so the 4 surgical groups. Now, when you combine all these, the 3 patient clusters and the 4 surgery clusters, this is what you get in terms of a efficiency grid, looking at all permutations, so form 12 subgroups. And then now in these subgroups, you look at the patient-reported outcomes, which is given in the blue here, which is the improvement over baseline, and the major complication rate, which is given in red. So this is kind of to compare the risk-benefit, risk being complications and benefit being improvement. So let's look at an example here, how to interpret this data. So for example, the old revision category, which had cluster 1 and 4, which is basically the 3-column osteotomies and the SPOs, when you look at the complication rate, it is high. It is among the higher amongst all the groups. But also when you look at the blue, they also had the maximum improvement over baseline of patient-reported outcomes. So this is one way that this classification helps to look at data. So in discussion, overall, this one surprising thing was that they did not find the sagittal spinopelvic parameters were primary distinguishing factors among patient clusters, which we know from previous studies. And then this kind of analysis generates a lot of hypotheses for further research. For example, which type of patient experiences the greatest improvement? They found that elderly patients with the worst initial status improved the most despite the greatest risk of complication. But when you look at the benefit to risk ratio, then less invasive approaches may be associated with a more favorable risk benefit ratio. So they're important for hypothesis generation. Some of the strengths of the study, it's multi-center prospective across 2 continents, it's data-driven, which you talked about. They included a lot of different variables, and it provides a novel concept for further ASD classification and to compare at the same time in clusters the efficacy and safety of these surgeries as a guide to treatment. Some limitations, machine learning thrives on data, so still a small sample size for machine learning techniques. Some technical aspects, they did not say how the multi-dimensional data was handled. There are various methods of doing it, so they do not go into much detail for those who understand it. And they did not include any clinical or frailty measures such as bone mineral density or other medical comorbidities, which are important, we know. Moving forward, some points of caution that institutions doing, employing these techniques and the journals reviewing such articles, I think they need to have increasing expertise in these so that you can actually critique and kind of sift out which are the more accurate ones and which are likely to help in the future. Because as we see, there's a lot of these articles coming out, but we want to know and discriminate which are the ones which are useful. And then with prospective, we need multi-center data for this because we need high patient volumes. So we need to move towards standardized data collection parameters and techniques so that we can combine data. In conclusion, the authors say that the unsupervised AI-based hierarchical clustering provides a novel classification method with simultaneous analysis of more patient variables than existing classification schemes. And this may help in pre-op decision-making and help educate surgeons on which treatment patterns lead optimal improvement with lowest risk. Thank you for everyone, and I'm happy to take any questions.
Maybe I'll just step in with another comment on this. This is all fascinating, fascinating work. The concern that I really have with this is we use the AI for preoperative decision making, and we see that the patient is in one of the high-risk clusters. Are we still going to be able to offer that patient treatment, or is somebody at some point going to tell us, unless this patient sits in this cluster with this risk, you're not going to be operating? And that is a big issue that I think we as surgeons are going to have to address, because at some point when this information does get out there, we know people are going to try to shut us down. They're going to say, no, you cannot operate on this patient because you do not have a 99.5% chance of improving this patient. He's got a 10% risk rate or a 20%, or she's got a 30% risk rate. So where do you feel we go with this data? How do we justify our existence with this data?
Yeah, I totally agree, Dr. Lieberman. I think the more data we have, the intent is to help us. But when we look at it, the more objective data we have, that gives others, I mean patients, payers, hospitals, to come back and say, all right, this is the metric that you need to meet, or this is what the data says, and you haven't been meeting it. So I think it is up to the surgeons to, while we're doing this analysis and coming up with all these metrics, but also to decide. I think this is an important tool to help objectify the risk, but in clinical decision-making, we'll really have to take charge and say, all right, this is an acceptable threshold above which surgery is not warranted. But the decision has to come from us. And it's a difficult decision, because once we have all these objective risk parameters and the risk ratios, it's hard to justify what is right and what is not. So I think it's one of the biggest concerns, which I'm not sure how to address, but I think at this point, it's, at least we have to move towards the right methods to arrive to that conclusion or threshold. But at this point, I'm not sure where this is going to be and who takes charge of all of this.
Fair enough.
Next.
All right, good morning, y'all. My name is Sean Adams, another resident here at University of Louisville. To build off of Nikhil's talk, he talked about having standardized data collection in a way, and wouldn't it be nice if we had ways to analyze our spinal pelvic parameters, curvatures preoperatively, postoperatively, that didn't have so much inter and intra observer variability. So this paper is going to be about automated analysis of the imaging. Let's see if somebody have control. We want to advance me. So key points that we're going to talk about, and this was a little bit of application of deep learning to this, spinal pelvic parameters, and how that's going to move forward. So we don't need to belabor the point. This is going to be a subset of artificial intelligence. In going forward, artificial intelligence, next slide, is, there we go, I have control, can be broken down into machine learning techniques, and a subset of that even is what's called deep learning. And this is going to be an application of deep learning techniques, which is modeled off of a neural network. So the purpose of this paper, and somehow we've skipped it maybe in my vigor to move along here. Here we go. So this was a paper from the European Spine Journal in 2019 entitled Fully Automated Radiological Analysis of Spine Disorders and Deformities, a Deep Learning Approach, from this Italian group. Sorry for the back and forth. So what they wanted to do is develop an automated method for creating 3D reconstructions of spinal pathology to not be limited by one particular set of pathologies, pediatric scoliosis or adult deformity or some subset of degenerative phenomena. But you could input nearly all of your AP and lateral radiographs into the system and get out good determinations of their parameters. So what they did is they took approximately 500 images, both AP and lateral, from their institution with IRB approval. And of those 500 AP and lateral images, they went through and manually labeled the 78 different landmarks, including end plates and hip centers and SI parameters. So that was then a subset of those 450 were fed through the deep learning model in a structured learning. And what's involved with that is we give the machine an input and show it what the answer is. And after repeated exposure, it learns how to determine those things. Of those 450 that were plugged in, then used 50 to serve as test points. And then they were fed those 50 images into the system for it to automatically determine the endpoints, looking like this. So superior centers of superior and inferior end plates of the various levels, and hip centers, sacral end plates, and this totals up to 39 parameters in each cut. So a 78 total that it's trying to determine. And again, this was done, and then a 3D model, which is represented by the green line here, was generated off of a curve that fit those lines. So a polynomial was then created to estimate the three-dimensional curve of the spine and generate the curvature of lumbar lordosis and thoracic kyphosis and the various parameters. And you can see here, not all of the images are the same, meaning that not all the pathologies are the same. Here, they're just showing that they were able to do this with mainly 36-inch type films with the cervicothoracic and lumbar spines included with the hips, and even feeding in full-length images of people standing erect there. So what they were able to do was show that this was able to create a three-dimensional model that to the eye looked pretty fit to the curve of the spine. So those green lines previously matched the curve of the spine to the naked eye. However, when subjected to quantitative analysis, it seemed that this is not 100% effective or 100% accurate, but did approximate that. So with the quantitative analysis, it was shown that several of the measurements, including lumbar lordosis, were off by a good bit of error. So the lumbar lordosis in particular was off by 11.5 degrees, a standard error. So the correlation, as you can see here in the graph, fits pretty well, but the deviation from the center varies both sides pretty dramatically. The best fit for the automated analysis was actually pelvic tilt. And pelvic tilt here, has a very nice correlation and a much tighter variability, only being off plus or minus 2.5 degrees, which is a lot more accurate and closer to what's documented for inter-observer variability in manual imaging and labeling of these things. So they achieved their goal. It was broadly applicable to images of people who, there was even 50 images of people who had been previously instrumented. So even with instrumentation in place, the deep learning method was able to discern these radiographic points and build their model. There is some limitations though, because it is not ready for prime time kind of thing, in that it still has some quantitative variability that would be beyond, I think, what most of us would find acceptable. Plus or minus 10 degrees of lumbar lordosis may make or break or determine whether you created appropriate revision or correction of deformity. But it is a first step. Previously, this has been done with more narrow sets of pathologies, so it fit to one group of patients, but this is a first step to a broader application of that technology. There's a couple ideas of why it may be off in some areas, but I think it's going to work towards being able to do this in an automated fashion, decreasing the amount of human hours put into it to label all these places. And then this can then be applied to large data sets, to clinical studies, to comparing outcomes between different places, and eliminating some of the human variability and error. So take-home messages, it is possible or feasible, they said, although it's not, the accuracy isn't quite where we like it. This deep learning method certainly has shown a strength in this application, and in feeding it images that aren't completely standardized, that come from different imaging sets in that different pathologies, and even 36-inch versus full standing scans. It was able to discern the imaging. So a good first step. And then there's a lot of potential applications of this. And again, they point out the large scale trials, I think, would be a nice way to standardize some of the data that we're looking at. Without dependence on the people who are taking the message or the measurements. Anybody have any thoughts or questions on that?
I have a general question. I'll jump in one more time.
Great.
We've heard the term artificial intelligence, machine learning, deep learning with the neural networks, but we haven't heard you guys talk about predictive analytics or a definition of predictive analytics. And that's a term that I hear bounced around over and over again. Any comments on where that term fits in the grand scheme of artificial intelligence?
So obviously, as I showed earlier, these are a nested set of things. Artificial intelligence is just broadly trying to get a machine to mimic some sort of biological type or human type decision making, right? And then from there, the decisions become more and more complex. The deep learning method, you provide a set of general rules without having to code for each individual decision by allowing for multiple layers, almost like visual processing is accomplished in the human brain, in that certain neurons are fired with a line of a certain orientation or a color or movement, and then that combination is then interpreted by the neural network to create some visual perception. The interpretive analytics, I'm trying to think of how to, like, I don't claim to be an expert.
Yeah, I can answer that, Sean.
Okay.
So the predictive analytics is kind of the broader term for clinical prediction, and includes AI methods, but it also includes the traditional statistical methods like non-AI methods. And so the predictive analytics has been the broader term for a variety of ways to predict clinical outcomes, to predict hospital resource utilization, a whole number of different outcomes. But it uses methodologies that are broader than the AI field. AI is mostly artificial neural networks and machine learning, but you can do predictive analytics using non-AI methodologies. For example, the traditional regression methods and traditional multivariate regression would be an example.
Fair enough. Thank you.
All right. Hello, everyone. This is the last presentation. I'm Dr. Sharma here. I'm one of the US6 residents at University of Louisville. I'll be presenting on application of AI in imaging. So this is a paper published in the European Spine Journal in 2016. And this talked about automation of reading of radiological features using MRI of the lumbar spine, and they basically compared it with the expert radiologist. This is a study out of Oxford from UK. Let me see if I can move this one. Sorry, I don't think I have the control here. Actually, if you can give me the control, please. Okay. All right. So a little bit of background: back pain. Oops, sorry. Okay. Okay. So back pain is one of the most important cause of lifelong disability. 85% have no clear-cut diagnosis, but degenerative disc disease is present in majority of MRI scans done in these patients. And on the other hand, majority of patients with degenerative disc disease are asymptomatic. And why do we think that there is this discrepancy? It's because of the lack of definition of features and different human brains basically interpreting these results. So improvement in the consistency, accuracy, and objectivity of measurements of radiological features would improve understanding and basically making it more uniform. In light of these, 5-month score was introduced in 2016, which requires human input though. So with this background, it's not moving. Okay, with this background, authors of the study designed the study to automate the grading process of the spinal MRI for all radiological features, and they quoted 3 key benefits. First is results are generated consistently. Radiologists can concentrate their attention and expertise on alerts and potential problematic areas, and it would help researchers to have to measure cohorts containing large amount of lumbar MRI data. Okay, regarding method. I apologize, it's not moving the way I prefer.
If you just want to say next slide, I can move
Okay.
forward. Yeah.
So, okay, perfect. Can you go back a slide, please? Perfect. So, in one, yeah, this. Thank you. So regarding data set, the authors use GenoDisc project. It is a project out of UK. It's a multi-center database essentially, in which patients who seek secondary care for their back pain and spinal problem, they have their data stored, including imaging features. This study is out of UK, Hungary, Slovenia, and Italy. Exclusion criteria was subjects whose MRI was of poor quality, non-DICOM format, and used only limited scans. And then these scans were read and reviewed by experienced spinal radiologists. Next slide, please. So it's around 12,000 discs and six discs per patient and their scores. And the authors divided 90% in the training set and 10% in the independent sample, basically test sample. And test set was used to test the accuracy or concurrent validity of the automated ratings. And that was compared with the experienced radiologist. And as this figure shows, the MRI basically is input into the system, and the system delineated the vertebral bodies. And after delineating the vertebral bodies, they basically look at the volume of the disc and used a reference and then gave scores on that. Next slide, please. As shown in this figure, these vertebral bodies were automated, all the lumbar vertebrae, and after calculating the volume of the individual vertebrae, the disc space were calculated, and then the scores were given as shown in the next slide. In the second part of the study, a classifier which predicts the radiological features is basically trained using the detected region as the input. And then these prior determinations of the radiological features from the experienced radiologist assessment was taken as the output. Each intervertebral level disc possesses 8 scores, as we're going to see in the next slides. And CNN, which is convolutional neural network, was used. It's a type of deep learning algorithm, and which is basically used in which the inputs were given to the machine, and based on preferences, like each input is weighted according to the according to the clinical relevance of that particular variable, and that's how the machine basically takes the input and weights it and gets the output. As shown in this slide, the radiological features fiber grade, which is 5-point grade, and which is based basically on the homogeneity of the disc, and as well as just a second. Homogeneity of the disc as well as height of the disc. The second point is disc narrowing, which is based, which is again a 4-point grade, which is based on height compared to the normal adjacent disc. The other variables are just bimodal bimodal variables, spondy, central canal stenosis, and plate defect and marrow changes. Next slide, please. As shown in this figure, this is just an example of these are just the examples of a couple of images. Like the top on the right, it shows a fiber grade 1, in which we can see the homogeneity of the disc space, and there is and the disc narrowing, which is grade 1. There is no spondy, and that's how these spaces were graded. Next slide, please. In terms of statistical analysis, the performance measure was used for validation was class average accuracy. It means just comparing with the output from expert radiologist, and machine output was compared to the expert radiologist. For their benchmark, the authors claim that the average class inter-rater agreement was calculated from 2 separate sets of labels by the same radiologist on a subset of data set that consists of 121 patients. So essentially comparing the radiologist reliability against the reproducibility of the model. Next slide, please. In terms of results, these are just the distribution of different output variables that were looked in the study. The only point I would like to mention here is the bimodal variables, which are very infrequent in occurrence. Like spondy was seen only in 469 discs, spaces, central canal was 710. So it just shows you, compared to the rest of the variables, the numbers are very limited. Next slide, please. This table basically shows the results, class average accuracy of the system compared to the radiologist. As we see in all the output variables going from fiber grade to marrow changes, it varies from 70% to all the way to 96%, which shows a pretty good accuracy in terms of comparison. But if you look at reliability coefficient, reliability, it means reproducibility of the system, which is good only at two output variables, which is fiber grade and this narrowing, and the rest of the variables, it's almost like flipping a coin. So that may be related to because the numbers were very less, one, and that the system was not trained to detect this. And this authors also claim that only 4% of the desks in the test have difference of more than 1 fiber grade between the model determinant and the radiologist, expert radiologist opinion. Next slide, please. So these are the bar graphs showing visually the differences in terms of radiologist opinion as well as the model opinion about the outputs. And it shows fairly consistent outcomes and accuracy with the radiologist. Next slide, please. Based on this model, authors also calculated what is called as evidenced hotspots. By this, they mean like where the pathology lies. If the it's basically the clustering of the numbers of the pathology, like in the end plate, if the pathology is more consistent in the upper end plate versus lower end plate, upper marrow versus lower marrow, presence of spondy versus not. So the focus of pathology, which is helpful in terms of radiologists can focus on that part of the scans. So which is kind of interesting in this study. Next slide, please. So based on this study, authors concluded that radiological scores can be predicted to an excellent standard using only the disk-specific measurements assessments as a reference set. This can be applied to any medical task where label grading might be available only for a small region or specific anatomy of the image. And automated reading is to produce a numerical signal score that would provide a scale of degeneration and so avoid an arbitrary categorization into artificial grades. So basically more consistent in terms of outputs using these algorithms. Next slide, please. In terms of limitations, the major limitation of this kind of study is selection bias. With limited geographical sample, this is based out of UK study. So whether this can be generalized to all the patients or not, that's a question. And system is not trained for reliability or reproducibility. So although it matches pretty well in terms of accuracy with the expert radiologist, however, reliability was a question in this study. And the limited number of cases with the spondylolisthesis and end plate changes, as we mentioned, as we saw in the results section. Next slide, please. Thank you. I'm ready to take any questions.
That was Scott Blumenthal here. That was nicely done. Two of the senior authors on on the paper, Jill Urban and Michelle Battier actually have a bigger picture in mind for gathering this data. It's they're leading a task force in one of the academic spine societies to eliminate the term degenerative disc disease because it's just too broad and non-specific, and more accurately categorize the different phenotypes of disc degeneration. And this is the kind of the beginning of the nidus of a lot of data, so that maybe in some period of time we'll have a more specific way to diagnose the way that MRIs and X-rays and CTs look at disc degeneration into a more specific diagnosis.
I see. Thank you so much. That's great.
Dr. Blumenthal, do you think that would really help elucidate the relationship between the MRI and the back pain?
I think that's the hope, is by using big data to be able to identify phenotypes of disc degeneration that are more specifically related to symptoms as opposed to normal aging changes of the spine. That's the hope, but it's going to take a lot of data.
Thank you, guys. Thank you very much for excellent presentations and good thought-provoking discussion. Thank you to Seattle Science Foundation. Everybody clean your CME and have a good weekend. Stay safe and happy Easter.
Thank you.
Thank you very much. Thanks, Seattle Foundation.
Thank you for the opportunity.